Thanks. Hi everyone. Thanks for having me. I'm very excited to talk about my job, which is a pretty fun job. I work at Origin as an exercise physiologist and I've been here for about 3 years. Today I'm just going to talk about my journey of sort of entering the service that already existed and what I've done with it since and where I think we could be heading in the future. I'm going to focus strongly on the implementation as said in the introduction, and also just explaining a little bit about my day-to-day job. So first of all, what is an exercise physiologist? A lot of people haven't heard of this condition and it's relatively new within the allied health field. So it is a tertiary qualified allied health professional. So you do a Bachelor's of Exercise Science and then a Master's of Exercise Physiology. And we tend to specialise in the delivery of exercise prescription to people with chronic health conditions. At university, I didn't study mental health, but it's been added as a chronic health condition. So it's definitely an emerging field for us as people to deliver treatment for people with mental health conditions. And in terms of our knowledge of behaviour change and motivational interviewing, I think it's quite a lovely fit for us to be working in this client base. So I get asked very often, are you the personal trainer? And it's been too many times for me to care anymore, but just so you do know, personal trainers usually get around about 6 weeks to 12 months of education, and my HECS bill is a lot higher than that. Personal trainers are absolutely great though, and we do link in with them in the community. There's no reason why they can't work with the population that we're talking about as well. And it's really just about creating a wellness plan. The reason why EPs are kind of in this setting and why we'd advocate for us to be employed over personal trainers is we just do have that extensive knowledge of different chronic health conditions which are evident in this population group. And we do use exercise prescription and behaviour change techniques as part of our treatment. If you're looking at physiotherapy, it's pretty similar to EPs. They do use like a hands-on approach and they tend to specialise in the diagnosis of musculoskeletal conditions, but they do expand into motivational interviewing and behaviour change principles as well. So there's definitely a lot of overlap with us working together. So the physical health snapshot, this is not new news, I'm sure, to a lot of people in the room. So I'll just sort of relay the demographic of the people that we're working with. So we do know that the physical health outcomes are a lot worse for people with a severe mental illness. Smoking rates are a lot higher, poor nutrition, sedentary behaviour, obesity, higher rates of cardiometabolic disease, and a 10 to 25 year gap in their life expectancy. So what lifestyle interventions aim to do is help reduce these risk factors. So we aim to provide support and direction to physical health screening practices. We aim to not just screen, but intervene. Thanks, Andrew Watkins, for that nice little line. To help with symptom management of lots of different symptoms that people have with mental health conditions. And to increase fitness. This is definitely something I'm going to expand on later. We need to shift the focus away from weight and towards fitness. The fitter you are, the longer you will live. It's evidence-based and it's definitely something that we can be talking a lot more about. The prevention of chronic illnesses as well is a big area that we need to look at. All of these things up on the screen are preventable, and there's no reason why we don't have a duty of care to provide that treatment to people entering mental health services. So how did we get here? In 2014, the psychosocial team, heavily led by Gina Woodhead, who's an excellent chief OT, met with ACU and they said, hey, we've noticed that our clients have really poor physical health outcomes, and in particular can be associated with the antipsychotic weight gain that we're seeing, and we want to do something about it. We're the groups team, we like to do different social groups, and we want to add a physical element aspect. So out of that conversation, there came an agreement where ACU said, all right, what if we give you an EP for 6 months? We'll pay for them. We'll put them in your service and they'll take students and they'll start to create a bit of a program. So they did a 6-month pilot and they had students on 6-week placements. They had 15 people referred per month over this time. In the first month, 37% attended their appointments, and then in the second month, 60% of people attended their appointments. So even in that short time frame, there was a bit of momentum growing within offering some physical health options for people in a mental health setting. The average attendance of each person that saw an EP was 3 sessions over this 6-month period. After this pilot program, they said, all right, seems like a pretty good idea, let's get an EP of our own. So in 2015, Origin made a commitment to hire an EP, which is a pretty big deal because we know that comes with a bit of money. So they've put an investment in, we're going to address the physical health of our clients. So they appointed an EP. In 2016, a dietitian joined the team, and that's when I came on board as well. In 2017, we saw an increase in EFT, so the amount of time that we were working. And in 2019, it's pretty exciting. We're talking about implementing a physical health stream within the service. My day-to-day work at the moment, through the growth over those 3 years, includes community partnerships, groups, one-to-one programming. We've received grants to build and upgrade gym facilities, and the beginning of automated referrals, particularly looking at the clozapine clinic. We've also got a successful student program with ACU, and we tend to see students for around about 6 weeks throughout the year. And when I say we, I'm the only EP that works here, so that's the stuff that I do. So what's the Origin Snapshot? So here's just a bit of data on the average client that might walk into my doors. So in terms of someone's BMI, so their body weight associated with their height, the average person that I'll meet does fit into the obese category. In terms of using the SYMPAC tool, so we've spoken about a few tools today around measuring physical activity. I use the SYMPAC, which is the short form. It's just 1 page, and it kind of captures movement and sedentary activity. And we did a bit of a pilot study, and I found it quite useful because there's a lot of sedentary time in this population. So what we found out is most people that I meet report that they spend around about 10 hours in bed, so that's them sleeping at night or just being in bed. 9 hours sedentary during the day, so not moving. It might be sitting in a car, sitting in a lecture, watching television, eating, so a lot of our day is sedentary. Sitting in a lecture. 1 hour napping a day, which is pretty common with a lot of the medication and side effects that people experience. People reported, I was surprised by this, an average of 30 minutes walking a day and 1 exercise session a week. So surprising data in some ways. So we know that the average client that I see is pretty sedentary, but might be doing some movement, which is great. In terms of the kind of referrals that I see, those anagrams, they just stand for different teams within the Origin sector. So the main takeaways, 50% of the clients I see are from the EPIC team, which is people experiencing some form of psychosis. So they're a high percentage of the referrals that I see, coming second to the PACE team, the mood team, and the hype team. So let's look at some of the physical health initiatives that have sort of helped guide the way that we've set up the service here. So one form that I keep coming back to is the HEAL Declaration. This was written by the people up in Sydney, Simon Rosenbaum, Oscar Lederman, a bunch of other EPs and other professionals, and they said, all right, people are entering a mental health service and they're leaving not as good as we found them in terms of their physical health. And that's where we're seeing these really scary life expectancy gap changes. So they've created a declaration to say, hey, we actually want to make measurable targets in fixing this. And I think it's time that Origin and other mental health services adopt this as a declaration, set targets to measure it, and actually try to achieve it. And I think we have a duty of care to do that for the clients entering our service. The other statements that I'm being guided by is the ESSA consensus statement. This is definitely worth a read if you're working in a mental health setting and you're thinking, okay, we need some form of movement, we need some form of physical activity in our service, but where do we start? This document just outlines the role of exercise physiologists and the impact that they can have in the service. But as a starting point, there's no reason why the existing staff can't adopt some of these strategies to begin with. And lastly, I really liked the Living Well report from New South Wales, and it just talks about the evidence-based programs that already exist. And the main outcomes that I kind of got from that is you want about 12 weeks of intervention. You do need health coaching, and this is quite important. So we know that even with healthy populations, you can't just tell someone to go and exercise and they'll go and do it and get a six-pack. Like, it's a bit harder than that. And it's even harder for our population that have even more barriers than the healthy population. So the health coaching and support aspect of things seems to be quite an important key. I've kind of added into my service asking people what kind of follow-up and support they would like. We offer SMS, we give them a call, and we might say, hey, you know, if you're struggling, do you want a bit of encouragement? Do you want to be left alone? And just setting up those support practices, envisioning, let's forecast when things are going great, this is the plan we've got. What about when things aren't going great? What should we do in those moments, and how can we expect that and still give you support in that time? And the other big takeaway was diet and exercise programs in combination tend to have the best outcomes. So what are the main benefits of these lifestyle interventions? So in terms of mental health benefits, we've got symptom management. So that's a really big one, and that would almost be reason alone to refer someone to the service. There's sort of mixed evidence on this, but I tend to tell people, look, everyone has slightly different responses to exercise. Let's see what yours is. Some people find their mood changes from one bout of exercise. Some people don't. Some people find it's helpful for their symptoms. If you have things like schizophrenia, it can be really helpful for positive symptoms. And we know that there's effects in depression and anxiety as well. In terms of the physical health outcomes, we're looking at reducing the risk of cardiometabolic disease, reducing waist circumference, looking at body mass, and reducing high blood pressure. Now, exercise as a standalone probably isn't going to impact all of those physical health outcomes. The biggest change that you'll probably see that we should continue to focus on is an increase in fitness, and we usually measure this through like aerobic fitness kind of training. The most simple way to do that would probably be a 6-minute walk test. Look, I tried it on my first day. It's pretty boring. And when you're trying to engage 15 to 24-year-olds, they don't want to walk up and down a hallway for 6 minutes. So I had to come up with a few other funner tests. So what does my day-to-day look like? Here's just a few outcomes of kind of stuff that I'd fill my week with. Number 1 would be metabolic monitoring. Unfortunately, the completion rates of this is awful and quite terrifying. So this is definitely an area that we need to just put our hand up and say, we're pretty bad at this, and let's figure out a way to improve. So I call it catching. If I meet a new client, have a look, has their metabolic monitoring been done in maybe 3 months, no, 6 months, no, 12 months, okay, we've caught it, let's do it. So basically that old risk strategy, if you see something, say something. It's like a bit of water on the floor. If it hasn't been done, just do it. So I'll do metabolic monitoring for clients, and then from there try to work with the treating team about what referrals need to happen. Do we recommend this patient get some bloods done? Do they maybe need to check in with their GP? Do we need to look at what medication they're on? Next to that, health coaching techniques. That's our lovely Jane Lynch up there. So health coaching techniques, I like to use motivational interviewing. These might include like fishing for change talk and really talking to people around listening to what they're saying, listening to what their goals are. We know that consumers want to talk about their physical health, and providing them with a really safe space to do that, and thinking about, okay, well, what would the next steps be for you if you were to start making some changes. Offering phone calls, SMS support, and to follow up on young people's goals. The next thing I might do in my day is go on a gym visit. We've got a few community partnerships, so I might go to a gym with a young person near their home and set them up with a program, and we might do it together, and then hopefully in the long term they can continue to do that without the presence of me there. We have community links such as boxing, netball or basketball programs. These are heavily supported by Reclink. And then we also have Origin-led groups where a client might see their case manager and then they might stay for their fitness group afterwards. And we offer these at our Parkfield sites, at our Sunshine sites, and also in our inpatient facility. Lastly, home exercise programming is something that we offer. People might not feel like they want to come in for a group, so I might see people individually, do a bit of an assessment and give them a bit of a plan of what to take away, and then I'll try to see them within the week. Opportunities for the future include aiming to do more staff training so that staff can also pick up on maybe if someone's really sedentary, to just have recommendations of, hey, have you thought about moving more? Have you thought about physical activity? Did you know it can help some people with symptom management? And starting that change talk so that we're all kind of saying the same thing. I think sometimes when you get specialist services in, what can happen is we handball all of the discussion around physical health to those individuals. A good example might be, I don't really feel qualified to talk to someone about their diet. But if they're drinking soft drink all day, anyone could say, have you thought about reducing your soft drink intake? It might be a good idea. So I think giving ourselves permission to have those conversations, and it can be kind of nice to also be vulnerable with your young people and say, yeah, I really struggle with that as well, or I find it hard to get motivated. What sort of physical activity do you like to do? And it can be nice just to break down those power differentials that we see in mental health settings and reduce the stigma there, and just talk as two humans who are both trying to maybe think about their health and to be a healthier person. There's been a bit of good evidence with looking at staff initiatives, so that's something that I'd like to introduce in the future as well. It can also increase awareness of what is an EP in the service. Staff get to have the experience of being the client, working on their mental health, and we know unfortunately that staff in mental health settings also have slightly worse physical health than comparative to other services. So may as well work on us as well. So some of the community partnerships I've set up, I'm pretty stoked about. We've got some really good connections in the community. The first one is Yogahood. These are a trauma-informed yoga care service. They offer 6-week blocks to people, and they come in and provide you with a yoga instructor. We've done quite a few blocks with them. After the completion of the course, the young people get a yoga mat from Lululemon, which is pretty great. So they're an excellent partnership that we've built up. And there's no reason why others couldn't reach out to them and also ask for those services to come in completely free as well. Boxing. Recently we've rolled out our first boxing class with the help of lovely clinician and very talented Craig McNeil at the Origin Parkfield site. It's had excellent attendance rates. We do our classes in blocks now. We used to just sort of roll them through and people's attendance kind of wasn't as good. So we've tried some 6-week pilots, but looking at the evidence, we'll probably move to 12-week blocks once we know what kind of exercise we'd like to continue to deliver. Next is Reclink Australia. So this company provides Origin with lots of different referral pathways. They're most known for their Reclink Cup that they do once a year in the AFL space, but they offer our clients with pretty much free gym access to lots of different gyms. So often I might go to North Melbourne Rec Centre or Melbourne City Baths and have a young person come with me, pay our $2, and then we just do a workout together. I tend to make an effort to not wear my lanyard, to not look like I'm a clinician in that moment. We're just two people going to the gym, doing a workout, and then I get to do a workout too, which is always fun. And it kind of normalises the activity a little bit more. So as a case manager, there's no reason why you can't go for a bit of a walk with your client or just start to normalise and role model that physical activity as well. So some big wins in the EP program. So we've recently obtained a grant to upgrade our inpatient facility. So we've got a new gym there as of last week, which is really exciting. And part of this upgrade includes, we've ordered a bunch of Fitbits. So I think what we'll be doing is rolling out some staff programming and having some step challenges and building a bit of excitement around the staff. And then hopefully the literature tells us that that'll increase referral rates for young people to also have those experiences of wearing fitness devices and being a bit more motivated about their own movement. So next I'm going to talk about some challenges that I've sort of faced as an EP in a mental health service. Some of the difficult things is often you can feel a little bit isolated if you're someone working kind of by yourself without any other professions of the similar qualification to you. Having low staff has been really challenging. We've just recently changed the structure of our group program team, which has definitely impacted the way that we run our groups. And we've had to be a bit more resourceful and build up those communal linkages, or literally go around to case managers and ask them what their special skill is and then make them do a group with me. So we've found a yoga instructor and a boxing instructor so far, so hopefully I find someone who can like juggle or do acrobatics or something next. Antipsychotic weight gain is always going to be an ongoing challenge for anyone working in the physical health team in a mental health setting, and the timing of referrals is probably the biggest challenge that I experience. So I'm quite passionate about automated referrals and just making this standard care, because at the moment, unfortunately, because I'm an optional service, people don't want to meet me because I sound really scary on paper. It's like, hi, do you want to meet the exercise lady who's probably really mean and she'll make you run? But then they meet me in person and hopefully I'm a bit nice and I'm not going to make people run if they don't want to. So I think by making this an optional service, we're actually not providing people with that duty of care. You don't get asked when you join clozapine clinic if you want to have your bloods taken. It's actually really important to measure how your body's going when we're putting you on these risky medications. So why isn't it that we say, hey, for your clozapine appointment, you're seeing the nurse, you're seeing the doctor, and then you're booked in with the EP? So this is something that I feel really strongly about, and we've sort of spoken about introducing this in the framework of a wellness clinic that other services have done, and it's worked successfully, so why reinvent the wheel? It's something that we're hopefully going to start rolling out more formally this year. Some other challenges have been amotivation. It's probably the biggest thing that patients report to me as the reason why they're not able to exercise, and it's impacting where they're at. We use motivational strategies, motivational interviewing, stages of behaviour change, and there's different ways you can construct the way that you talk to these young people, and this is something that case managers do on a regular basis. We just need to use that framework and put physical health on the forefront of our mind when we're talking about that. Sometimes we accept a barrier, I'm not motivated, I don't want to do it, and we say, okay. But really digging deeper and kind of just understanding, okay, well, what sort of things would motivate you? Or understanding, have you done anything in the past? So having some strategies for how to talk about motivation can be really helpful, and applying it in a really non-judgmental way I think is quite an important skill. I think often we feel like we don't want to be sort of preaching to clients, or we feel maybe uncomfortable about our own physical activity, so we think, who am I to tell someone to go for a walk? But it's really about just the service that we're providing, and we're trying to provide educated information about physical activity and the health outcomes. Lastly, space and resources can be really hard. Most EPs that work in a mental health setting, similar to me, will go to several different sites across their week. So setting up camp and then putting everything away each day can be a little bit challenging, and also flying in and out and seeing staff once a week or whatnot can be a little bit tricky as well. So we're constantly looking for ways to sort of help improve this. Haven't really figured it out yet, but it's a challenge. So some solutions. Community partnerships, as I mentioned earlier, to help facilitate low staff and to build community linkages. So we can look at someone's wellness plan and look at their recovery and say, actually, you're kind of fitted here and it looks like you're already ready to link in with your gym. You don't need to do one-on-one with me. So really understanding where those community linkages fall in play so that our discharge options are a lot better for people. Automated referral pathways, so I spoke a little bit about this being standardised care and us changing the language around wanting to meet someone potentially scary and really mean, or you're booked in to see the reg and you're booked in to see Lauren. Understanding readiness for change is really important, and something I'm going to do to help with this is start to prioritise my referrals based on readiness for change, but also the needs of the individual. So there'll be certain clients, I get this all the time, like so-and-so hurt their knee, they want to see you, and I'm like, okay. fine. I'd love to do a knee assessment. I haven't done one in a little while, but they're probably slightly less important to me than someone who's maybe just gained like 12 kilos. So being able to prioritise and filter the needs of your service is really important. The Keeping Body in Mind project up in Sydney did this really well, where they pretty much said, we're not seeing anyone except people with first episode psychosis, and we're going to get it right. And then after we've done that project and it works, we're going to expand it to the next highest needs clients, those on clozapine, and then we're going to see if that works. So there's a few different options in terms of prioritising the service that we'll probably look at this year to try to get better outcomes, rather than just trying to see everybody. So I've touched on this a little bit earlier, but a really big message that I want to share with people today is exercise does not cause weight loss. Sometimes we're setting people up for failure, and I think it's really important the language and education we use around this topic. So we need to move beyond weight loss. Most clients will come to me and say, I want to lose weight, or I've gained all this weight from the medication, I just want to be thin again, I'll be happy when I lose all the weight. And it takes a little work to sort of start to break down those fixed beliefs on what your life might be like if the scales read a different number. What I try to do is focus on fitness, because I know that that'll help with life expectancy and symptom management. So they might get in the door based on wanting to lose weight, but if we say to them, great, let's try to lose weight, and then 4 weeks later they haven't seen any results, they're not going to come back, and they're going to have really negative experience, and they're potentially going to attribute that to exercise, and then be someone who says, oh, I've tried exercise, it doesn't work for me. So really shifting the focus away from weight and shifting it towards how you feel, what your strengths are, what do you want to be good at, what does your perfect week look like if you're an active person. There's a kind of much better strategies to focus on someone's wellness as opposed to what the number on the scales is. And a little bit of data. I went to the Equally Well symposium yesterday, and in general populations there is a 1 in 10 chance someone who is obese will enter the normal weight range. So we don't want to set people up for failure and encourage them to lose weight and to try to support them in that. We can acknowledge that that's a really important goal, but we might say to them, hey, these outcomes are probably a bit more likely. Are you happy to focus on them for now? And maybe weight is just not our top priority or not as important. So that's why we tend to take fitness measures and other measures to say, hey, well, we've just measured 5 things, so let's see which ones we can change. And maybe you could do more push-ups, and maybe you could do more squats in the coming weeks as opposed to the scales. So I'll just finish quickly with some of the guidelines for physical activity. I think we've already spoken a little bit about this today. So there's different ways to meet the guidelines. You can do your 150 minutes of moderate exercise or 300 minutes a week. Resistance training, strength training is recommended 2 days a week. But something that I found really interesting is there's actually sedentary guidelines now, and I feel like this is a little bit more applicable to a lot of people who are entering a mental health service. It's a bit overwhelming, I think, for anyone to look at these guidelines up on a screen. Like, I find it overwhelming, and I am very active. The way that they report it, like 150 minutes, I was like, that sounds like a lot of minutes. Like, I wonder how long a movie is. Like, do you have to be walking during a whole movie? Anyway. I like to sit and watch my movies. So the way I sort of look at it is it's more about movement, and it's more about increasing your movement. We know from the evidence that 10-minute blocks tend to be helpful, but for someone sedentary, making a plan for them when they're having a really low day, it might be getting out of bed, it might be going to the toilet, it might be setting an alarm and using the toilet that's upstairs instead of the one that's downstairs. So there's a lot of these strategies that people can just move a little bit more at home, and if you're setting those goals and they actually achieve it, then you're starting that strength-based approach of, oh, I did the thing, cool, maybe I could do it again. And I think sometimes we focus a little bit too much on the end goal of, like, when I'm running marathons, this is what my life will look like. But you really have to sort of start at square one with this population and make it a bit more bite-sized. So that sort of flows into the message of move more, sit less. I know some people have, the Fitbits and whatnot, and they'll vibrate if you don't sort of move enough, or we have standing desks and things like that. So we want to sort of provide our clients with those opportunities to be a little bit more active in their day as well. As I said, it might be just going. I have one client at the moment who just walks around his house. He's too paranoid to go outside, so that's fine. He's got his phone, he's got his step counter, and he just tries to clock up. We started with 3,000 steps, and now we're up to 7,000 steps a day, which is actually really good. So just setting those little goals can be helpful. Some people like watching the little YouTube workouts, some people like the apps on the phone, just about finding the right strategy for that person that works. So lastly, I'll just talk about like what to do with people that aren't really ready, or they don't maybe meet the criteria, or maybe they didn't get prioritised in my new fancy referral system that I'm running tomorrow. There's a few things that we can do to help sort of these people with their recovery journey. So providing as much information as possible and feeling comfortable to actually talk about exercise and physical activity, I think, is probably the first barrier to break down. Thinking about motivation and interviewing, forecasting with clients, what would it look like if you were to make a change? What sort of things would you like to do within your week? Are there any sports that you used to play? Things like that. Identifying their barriers, so what parts make it hard, what foreseeable things would make it challenging for us. Setting realistic goals. And really acknowledging like something's better than nothing's, just moving a little bit more might be the first step in their wellness program. Walking appointments are encouraged, or starting a walking group. These are all things you don't need any resources for, that anybody could do. Here's just some helpful kind of conversation starters. And if you take away one thing from today, it's how to talk about exercise. I kind of think about how smoking cessation has really been such a hot topic over the last 5 years, and how we've really embedded in mental health services a better approach to talking about smoking and to help offer people nicotine replacement therapy. And I think we could probably just apply the same model for exercise. We just need some tips of like how to talk about it. So just by simply asking someone, hey, are you someone who's exercising? Do you have any physical activity in your week? Would you like to change that? It's exactly the same philosophy that I apply when I ask someone, are you a smoker? Would you like to change that? It's a really non-judgmental way to just ask somebody where they're at, and you get a bit of a picture of kind of if they're in a stage ready for change or if they're not in a stage ready for change. So that's all I really wanted to cover today. Thanks a lot for listening.